Okay.
Perfect. Thank you.
You're welcome. No problem at all. Good afternoon, everyone. It's good to be back again with you. I think I presented last month with this group on the referral process for transition coordination agencies. And Sammy did ask me to come back and present a little bit on transition services and targeted case management transition coordination, or TCMTC. So that's a little bit what I'm going to be talking about today. Go ahead to the next slide, please, Susie. You can skip that one too. Okay, so I was going to start the presentation off by talking about transition services. And really, there with transition services and TCMTC, there is no versus or one against the other. Transition services is the overarching umbrella for transition coordination. So, just starting a little bit with transition services were created as a result of the success of the Colorado Choice Transition or CCT program. Some of you may remember that. That was a while ago. That was even before I started with the department. So I only know about that program in passing and things other people have told me. But what the HCPF did was develop transition services to include the most successful aspects of that CCT demonstration for ongoing Health First Colorado members or for Colorado Medicaid members. So underneath that transition services umbrella, there are going to be two primary things that coordination agencies work on. That's transition coordination and the transition benefits. Those are the two most successful parts of that CCT demonstration, and those are the ongoing benefits for Colorado. So think of transition services as the overarching umbrella. That's the overarching program. Under that program, there's transition coordination and then there's transition benefits. So that's kind of an overview of what transition services is. And we'll get into transition coordination and we'll get into some of those benefits on the next slide. You can just raise your hand or drop something in the chat if you have any questions. I speak really fast. It's just a habit I've never been able to kick. So let me know if you need me to repeat anything or go back. Next slide, please, Susie. So now we're going to talk about targeted case management transition coordination, or TCMTC, because this is the service or the benefit that is under the transition services umbrella. Targeted case management transition coordination is an optional Health First Colorado benefit, and it's available to Health First Colorado members. So these services are provided by an enrolled transition coordination agency. I won't get into the billing and all of that because I know that those aren't things that necessarily impact you. But the things that I really wanted you to be aware of are that these services are provided by the Transition Coordination Agency. The benefit provides the transition coordination support for any member or any eligible member who wants to transition from an institutional setting to a community setting. The benefit does include comprehensive testing or assessments for transition. There's a community needs assessment, there's a risk mitigation assessment, and then there's development of a transition plan. It starts with a referral, which is what I talked about last time I presented, and there is monitoring and follow-up activities after a transition is completed, if that is the route that the member decided to go. So that's targeted case management, transition coordination. You can go ahead to the next slide. So, as I mentioned before, transition services is the umbrella. So that's why this slide here is transition services. Under that umbrella, you have a few other specific transition supports or services that remain there. So HCBS benefits, this is another one that's under transition services. This is waiver eligibility. That's how it's determined. There are four specific services and supports that are underneath that waiver, and it really depends on which waiver you have. And like I said, I won't dig too deep into that either. I didn't want to get into the weeds. I wanted to stay pretty specific to the things that impact nursing facilities so that you all would have that information. But there are some of these services are specific to certain waivers, so just keep that in mind. And also keep in mind, these services are authorized by case management agencies or case managers. This isn't something that the transition coordination agency will authorize or start for the member. This starts with the case management agency. So the next benefit is targeted case management transition coordination. This is a state plan benefit. It does live in the targeted case management billing manual underneath that. So it's a benefit underneath targeted case management and it's transition coordination. So it's specific to transition services. It does ensure payment of services if long-term care Medicaid is denied. I also want to talk a little bit about housing. Housing is very specific to this Colorado transition plan. There are other states that have other transition plans and they do different things, but we modeled our program off of the success of CCT. And one thing they noticed then was housing was a very critical part of the transition process. As we know, living here in Colorado, housing is very important. And it's really a key benefit of our transition services because the need and support for it is very, very high. And it's also what sets our program apart from other states as well. So, transition services is the overarching umbrella. These three bullet points are the main benefits or services that are under that umbrella. Any questions so far? Let me go back to okay. So, next slide, please. There we are. Were you guys able to see the previous slide that had the bullet points? That was the last slide I was just talking to. I don't know if you all were able to see that. If someone could give me a thumbs up or let me know. Okay, thank you. I don't know if you all saw that, but those were the three bullet points I was saying that are under the transition services umbrella. But when I got back to the screen, it was on a different slide. So I just wanted to ensure you all saw it. So you can go to the next slide, please, Susie. Okay, so I'll get into, so now that we've talked about the transition services, the umbrella, all the benefits that are under the umbrella, waivers, all that jazz, how does this impact nursing facilities? Where do you all land in this? So the transition coordination agencies receive referrals from members in nursing facilities who are interested in transition services. So I know I talked about the referral process. I'll talk about that in a few slides later too, as well, kind of give you a screenshot of what that looks like. But that's where it begins for you all. The TCAs receive a referral, and then they're going to begin contact with the member in your facility to start that transition process. They are going to be in contact with you. You will be part of the care team because there's a whole team that is involved in the support of this member. The member is always provided the dignity of choice for transition. And the transition team, which does include nursing facility staff, has to respect the member's choice. That's something I always talk about because I know in some situations it may not seem like a member is a good candidate necessarily for transition, but we do allow members the dignity of choice. It is their choice. Now, if transition does end up not being a recommendation, that's something that we have a process for further down the road, but we always have to allow them the choice to transition if that's what they want. Transition coordinators or TCs, they work as a team with LCAs, nursing facility staff, CMAs, RAs, as a team and other necessary stakeholders to ensure the member has support for a healthy and safe transition. So that's kind of the role of the nursing facility through this transitions process and through transition services. I'm going to pause right there because I saw a chat, so I'm going to go see.
Yeah, I can read it. It's
Okay.
from Deborah Wilson. Can residents that want to transition from assisted living to the community receive help under this program, or is it just for nursing home residents?
That is a great question, Deborah. And yes, they can. If the resident wants to transition to an assisted living facility, this program can help them. And we have seen that happen before for other members. That is a choice for them. Great
So
question, too.
it actually says want to transition from assisted living to the
From,
community.
oh, I see. Let me double check on that one because I know they can transition to one. Let me see if they can transition from one. I'll follow up with that and get an answer for you, Deborah. I believe so, but let me confirm before we have a yes or no on that. Thank you for clarifying, Susie, too. Any other questions?
Looks like there's a new one. Nope, it's just saying, okay, thank you. Thanks, Deborah. Next slide,
Okay. Yes,
Jay.
please.
Okay,
Yes.
perfect.
So this might look a little familiar if you were in the presentation last month. I wanted to talk about the roles of and responsibilities. I won't go into each responsibility for each of these roles, but I did want to share these roles because these are going to be members of the transition team, which will also include many of you. So I just wanted you to be aware of who that would include. That would include LCAs, which are local contact agencies. They track referrals, they meet with the members to provide option counseling, and then they ultimately make the referral to a transition coordinator coordination agency or to the transition program. And then I get that referral now, and then I send that out to the corresponding TCA who matches up based on location and need and things like that. The next role is the TCA. That's the program that I oversee. So I work specifically and exclusively with transition coordination agencies. They facilitate the assessments for the community needs and the risk mitigation planning. And they also assist with obtaining housing. Like I said, that's a very, very important part of the Colorado Transitions Program. Next slide, please. Additionally, the CMA will be on the team. So they establish a HCBS eligibility. That was what I was talking about with the waivers. So that's going to start with them. Our TCAs, if they are having questions about waivers or eligibility or anything like that, they refer back to the CMAs for that support. And then we have RAISE, and they help the members understand their benefits. They manage physical and behavioral health benefits, and they connect members to service providers. I don't see RAISE on the team too often, but they can be sometimes. So we wanted to leave that role on there so you all are aware of who would be part of this transition team that's supporting the member. So you'll see these names and roles a lot throughout the transition process. Next slide. Okay. So this last slide is the transition coordination process. This is going to be what the transition coordination agency is going to do after they receive and accept a referral. So it starts, as you can see, with that first like light pink box with the referral being accepted. Then they're going to meet with the member and they're going to create the transition options team. That's going to be you, skilled nursing facilities and nursing facilities, LCAs, TCAs, CMAs, a lot of abbreviations there, sorry, a lot of acronyms there. So that team is formed in that second step. The TC then is going to facilitate the completion of the community needs assessment and the risk mitigation plan. They are also going to determine if the member meets MFP or money follows the person eligibility, which is going to provide additional benefits and supports when they transition. So that's always a step, and that usually is determined based on the responses from that community needs assessment. Um, if the member chooses MFP as the preferred supplemental provider, they can do that. The TC notifies the preferred supplemental service provider of any needed services and when services need to begin. Because what the transition coordinator is doing is they're working on setting everything up so that it's in place for this member once they are discharged from the facility and they are back into the community. The TC assists the member obtaining housing if needed, and a lot of times it is needed. It's one of the most kind of important parts and one of the most critical needs of the transitions services program. The TC coordinates discharge planning, and that's usually with you, the nursing facility. And then the transition occurs when critical services and household setup is complete. This TC provides post transition monitoring based on the member's risk level and performance. And that's pretty much the whole process. And you will be involved as far as even if you're in attending meetings, if you see a TC coming to your facility to meet with a member, but you'll see a lot of this happening in your facility because this is the process before they are discharged. As you can see, discharge doesn't happen until those last 2 to 3 steps. So that's the transition coordination process. We can go to the next slide. And I'm sorry, oh, thank you, Susie. I was looking at my presentation, so I didn't see yet. And I wanted to include some of the coding and regulations in here around transition coordination, around targeted case management, in case any of you are wanted to look it up anytime. If you like reading codes and regulations like me and you just want to see what it says, I did include a slide that has all that information. It has the rules and regulations regarding transition coordination services. So that is the presentation. Are there any other questions?
There is one, Jay, from Patricia Madrill. What part in the process does the business office manager in a SNF have in order for the facility to no longer be the payee for their income?
What part in the process what part in the process would the SNF no longer be the payee for any income? That's how I'm reading. Is that correct, Patricia?
Patricia, you can come off mute.
Yes, she said yes. Okay, that would be upon discharge. Once discharged, the discharge date is going to notify when the member is no longer there. So that's going to be all documented on the transition discharge. That's going to be documented on the discharge from the facility, but they're no longer the rep or payee once the member is discharged from the facility. How do they pay a housing fee if it has to be paid prior to discharge? So a housing fee to the facility, Patricia? Like if they owe money to the facility that's not covered by their income? Is that how I'm reading that? Oh, to a housing unit in the community. We have things in place. There's some funds that can be used sometimes. The transition coordinator will set up a plan for financial though. There will be a plan in place before discharge so that all of those things are covered and taken care of. And that's why the nursing facility will be, or the SNF will be part of the transition team. So they know what to expect and they know when they are no longer the payee. So there are funds in place to help the individual get set up, pay deposits and all of that. And then there's a lot of times they have a voucher and that voucher can sometimes take care of payment to get them into the facility. So I understand your question. How are they going to pay the nursing facility and pay deposits and first month's rent when they come out of a facility? It's how I was kind of reading that. And there are programs and funds and a plan in place to ensure that there is a smooth transition financially for them too, because that's one of the important things is not to put them in a situation where they're going to be unsafe or at risk to lose their housing. So all of those things are determined and planned out before someone is discharged from the facility. And there are funds that are available to take care of some of those initial costs to get placed into a housing in the community. You're welcome.
Awesome. Thank you, Jay, so much. Before we go to the next presenter, is there anyone else that has any questions for Jay? Going once, twice. Okay. Thank you so much, Jay. This was super helpful.
Good. Yeah,
So
you're welcome. No problem at all. I'm going to stay on since I'm recording. And if I get an answer to Deborah Wilson's question, I'll drop it in the chat. Okay.
awesome. Thank you so much. So we are going to now move on. Oh, sorry. Contact information for Jay. And if anybody needs that, let me know and I can send it to you as well. So we are going to move on to Jennifer Hansen, who is with Helping Hands Consulting. Thank you, Jennifer, for being here. If it's okay with you, I'll just go ahead and run the slideshow and you can just tell me when to go next. Okay. Oh, I think you're on mute. Let me unmute you.
So I'm Jennifer Hansen with Helping Hands Consulting. And essentially what we do here at Helping Hands Consulting is specialize in long-term care Medicaid and helping clients and families navigate that process. And therefore that in turn benefits nursing facilities. So I feel like before we get into the nitty-gritty of exactly what we can do to help you guys, I think the best way to do that is for me to back up and kind of tell you the way I got started. You can probably go to the next slide, Deborah. I was the long-term care policy specialist actually at the Department of Healthcare Policy and Financing, HCPF, for just shy of 3 years. And daily basis, I would get a call from a client, a family, a provider, a social worker, a corporate officer at a nursing facility trying to escalate a case to me because the case, the nursing facility had provided services for 3 months, 6 months, 8 months, and the case had gotten denied or it had gotten approved with a large gap in coverage. And so they would escalate a case to me to see if I could come in and intervene, and maybe tell the county that they did it wrong or, try to make it right for the nursing facility. And just what I found in that role is 9 times out of 10, I just couldn't do anything. A lot of times it was a valid denial or a correct effective date, even though it generated a gap in coverage. And what we just found is that, long-term care Medicaid is complicated. And a lot of times, people would get into the process, not realizing they didn't know what they didn't know, or, providers would feel like it was an easy case and they could help the individual. And once they got knee deep in it, it was a lot more complicated than they anticipated, and a little bit over their head, so to speak. And so a little over 15 years ago, I quit my job at HCPF to start Helping Hands Consulting, essentially with the purpose of providing an affordable and a knowledgeable source for clients and families to be able to hire to help navigate that long-term care Medicaid process. So essentially we can help anything with eligibility. And a few of those services range from, we can have as little as just one meeting with families. So let's say you were touring a family or a family just entered your building. They have a ton of questions. Maybe they have 6 months, a few years of money. Maybe that's even a few $100,000. That's a lot of money to me, but at a rate of $13,000 a month, all of a sudden $200,000, doesn't seem like so much. So we can always just sit down with a family and kind of look at their case and say, here's where you are, here's where you need to be, educate them on how to get there. If there's any options they have, discuss those options. And just kind of tee them up to make sure they're ready to go after the long-term care Medicaid when it's needed. What's also so important in those meetings is to talk to them about what not to do. Don't go give money away. Don't go do IRS gift limits. Don't deed your son onto your home, things like that. And just kind of informing them how that will affect them when the time comes. So we can just have as little as one meeting with the family. Or the most popular service we provide is we can help people from wherever they are in the process all the way through the eligibility determination. So what that typically looks like is that people will usually come to us with about anywhere from 1 month of money left to, a year's worth of money left. And we can guide them through the spend down. We can help them, collect all the bank statements, pension verifications, all the verifications needed. We'll complete all the documents for them. We're trying to look at it through Medicaid's eye. So our goal is to bring together a 100% complete packet. That way, when the county looks at it, they can process it and approve it, by touching it for the first time, so to speak. And again, in our ultimate goal, we stay on the case until you guys get your approved 5615, and it generates all the effective dates and things that you're looking for. If it doesn't, we will stay on the case until we get that corrected 5615 for you. Other things we can assist with: annual redeterminations, appeal. So let's say maybe you guys help somebody through the process, or they hired a different professional, helped them through the process. The decision was not favorable. We can always assess the situation and determine if it's worth filing an appeal. If it is, we can actually do non-attorney advocacy in the case of an appeal. So really what I'm saying here is, we can do anything with eligibility. In a perfect world, as someone identifies this situation for you, if you're touring them, in your facility, and they're not even there yet, or if y'all are in that first care conference or one of those care conferences, and they mention they're running out of money, ideally, you could give our information out to them. We would love for the family to call and hire us. We are hired by the family. We will keep you guys updated, and then we will, get them approved. In the event, though, that for whatever reason, the family won't hire us, whether it be they don't want to pay our fee, whether it be they don't know the importance of it, whatever have you. The facility, we actually do a lot of contracts with facilities where the facility can actually hire us to help with a particular case. So if y'all have a case where maybe the family's not cooperating, they're providing you information that you can tell is just a little over your head, you don't know how to treat it, we can get on those cases. Y'all see some gifting going on, this could be a hardship case. We do a lot of hardship cases. Anything that you just feel like you're going to need more help with, or the family's going to need more help with, the facility can always hire us if the family's not willing to help with those cases. And like I said, that could be, redetermination issues, initial application issues. I feel like facilities have gotten very used to writing off, 10 grand, 12 grand, 30 grand. It just seems more normal these days. And what you're going to find is that 9 times out of 10, we can actually assist with those cases. So we can assist really, hopefully just by doing the Medicaid. We have consultants who are just brilliant at coming in and getting verification that no one seems to be able to get, dealing with families, again, that no one's been able to deal with thus far. However, in the event it's more of an issue of authority, like John lands in your facility, John has no family, and John doesn't even know his name. He can't sign a check to spend down. He should not be signing a Medicaid application, more or less getting bank statements for you guys. Another service we can provide is that we can actually petition the court and become their court-appointed conservator. So in 2016, we just identified on occasion, we just can't, get somebody to get them through the Medicaid process if they don't have an authority figure, if they're not of capacity, obviously. So we can petition the court to become their court-appointed conservator. Or a less restrictive thing we can do if the person is of capacity, but they just can't get out and get their bank statements. They're just having trouble getting their pension verification. They really need someone of authority to help. we can actually become their financial power of attorney if needed, to help finish out, or start and finish out the Medicaid application. So we do provide those fiduciary services as well. We typically like to only do them, like, we're not trying to be a fiduciary for people who have multi-millions or anything like that. We really like for it to be in line with, a current Medicaid application or a future Medicaid application. We are able to sell homes and things like that through those conservatorships and power of attorneys. But for the most part, we like for it to be somebody who, we see Medicaid in their future, because again, it ties back to what we do, our bread and butter, the Medicaid. So, but what I will say, between the two services, just the straight Medicaid services and or the fiduciary services, we can intend to be a solution for about 99.999, if not to 100% of all your Medicaid problems. We talk to facilities all the time, and they have 2 or 3 cases, and there's, hundreds and thousands of dollars on the books. And it's something we could have helped with the whole time. You know what I mean? Pretty easy. At the very least, stopping the bleeding and getting through the long-term care Medicaid process and getting you a payer source ASAP. But also, like I said, we're trying to really, when I quit my job at HCPF to do this, it was really because I saw these facilities rendering services. And really, when Medicaid didn't pay the bill, the only party that really went down in flames was the nursing facility, right? Because they're the ones that really didn't get paid. Even though the client wasn't eligible, it didn't mean they had the money to pay the facility. So my ultimate goal in all this is to make sure nursing facilities do get, paid for the services they provide. And we at Helping Hands tend to have solutions for the majority of those problems that you guys have, whether it be the clients pay us directly or through some sort of facility contract. We do service the entire state of Colorado. So wherever you are, we can usually handle the case. And Deborah, and this was my presentation from the last one I did, so I apologize, I didn't follow these same slides. Do you mind just skipping to the end where our contact information is? There we go again. So if you're interested in learning more about what we do, I see some names on here, and I know that we already work with a lot of, I see some familiar social worker names. So but if you're not familiar with us and you just want to have a separate call, learn more about, what we do. If you have some cases, like we had a call with a new facility yesterday where they wanted to learn more about our services, and they just wanted to throw out a few cases to see like if it's in the wheelhouse of what we can help with. And we were able to help with all of them. So if y'all are interested in something like that, feel free, just give us a call, and we're happy to, set up a 15-30-minute call with your administrator, social work, business office manager, corporate officer, whoever it is, to talk more about those issues. And that's really all I have. What questions do you have? Sorry, I'm just looking through. I think most of these are from the chats I'm seeing are from the previous. Presentation.
Yeah, they're all from Jay's. Sorry.
Okay. Yeah, they're good. Well, thank you guys for letting me present. I look forward to hearing from some of you guys if you have issues. And yeah.
Thank you, Jennifer. Great
Thanks.
presentation. Yep. Nice to see you.
Nice to see you.
So next we're going to go to also, I think, is a very timely presentation about remote services by Derek Williams. And this is, I think, especially useful for a lot of our more rural communities where you're wondering what services are actually available to you and so these remote services can be really, really useful for people looking to transition back into the community. Welcome, Derek. Thank you for talking today. If it's okay with you, I'll do the slides and you can just tell me when to go.
Cool, that's fine. Good afternoon. I'm currently on CU Anschutz campus in a fishbowl. So the light turned out. That's why it's dark in here. So if it seemed weird, it's because it is. Anyway, good morning or good afternoon. My name is Derek. I'm the owner and administrator of Comfort Care Home Care. Next slide, please. And the one after that. All right, great. So I believe 3 things really. Number 1 is that no one should ever wait for more than 5 minutes for help to be on the way if they fall. Number two is that no one should return to the hospital or to a skilled nursing facility, in this case, within 3 months after staying with you. And then finally, primary caregiver of somebody that needs assistance with daily living shouldn't ever burn out. So I have built my agency to support all three of those things, and remote support or remote services is a huge part of that. Go ahead and go to the next slide. So I'll talk a little bit about what they are, which specifically are services that are available for seniors, the way that it can be paid for, and then ways that we can get started. So next slide. Okay, so exactly what are remote supports? And this is the definition provided by HCPF. Remote supports is the provision of support by staff at a remote location, and they're engaged with the participant to assist and respond to the participant's health, safety, and other needs through the use of technology and other devices. And each individual interaction with support staff can be scheduled, it could be on demand, or it can be in response to an alert from a device or technology equipment. And the type of equipment that I have available and where it's placed in the home, it all depends on the needs and the preferences of the individual. So I'll go into how that works now. Go ahead and next slide. Okay, so really the purpose and the benefit here is to help people live independently in their home, and also provide them with two-way virtual coaching. And basically it prolongs the need for institutionalized care or reduces the need to go back into institutionalized care. It is a good blend of both in-person care as well as remote support. And then finally, the remote care that I provide is 24/7. It is live care, so we do not use automated bots. And really, the benefits here are they improve and enhance safety and independence. There is proactive health monitoring, especially as they leave hospital or skilled nursing facilities. And then finally, the companionship piece of this cannot be understated. Go ahead and next slide. So specifically, with Comfort Care's remote support services is targeted towards seniors and people with disabilities. And number one is remote fall detectors. Number two is remote caregivers. The third part is really a add-on to the second and the fourth option, which is remote monitoring. I'll talk about how that works. And then finally, chronic disease management. So I'm going to go through a couple scenarios just to give you an idea of how this might work for your members, and then I can answer any questions as they come up. So next slide. All right, so the first scenario is using fall detection and remote caregiver, as well as in-person care. So in this case, this woman lives alone, is at a very high risk of falling. They receive 7 hours a day of in-person care, and the family is somewhat nearby, but they worry about their mom when she is alone in the home. And so what do? So what we've done is we've installed the fall detectors. They work 24/7. They do not require any buttons. They also do not need to be worn. They are non-intrusive sensors. They are active radar that sits on the wall and detects a fall. If she were to fall, then the remote care coordinator team is notified, and they can call the family, they can call a neighbor, and they could also call me at the home care agency to determine what to do next. And then remote caregiving, this live coordinator is available 24/7 to the resident or to the member. She is able to call anytime she would like to. She can participate in group calls and play bingo and Bible studies and book clubs and that type of thing um, through the app on her phone. And then she also receives a call every morning at 9 a.m. And they really just check on her to make sure that she's good, because her in-person caregivers don't come until 11 a.m. And of course, if there's anything concerning, the remote care coordinator team is going to alert the caregivers and the family right away so that they know what to do and can address it earlier if they need to. That's the first scenario. Nice blend of the two. Next slide, please. Okay. So this next scenario, this gentleman has a mild brain injury, also pain and arthritis and depression, lives alone, receives in-person care, homemaker services for 4 hours a week, but they also need reminders for daily tasks like taking their medications and also get lonely. So they are set up with a remote support system and they get a call every day from the remote care coordinator team. They get a video chat with the remote care coordinator. They also are able to participate in the group settings that I mentioned earlier. And then the app has been programmed with their medications. So they get an alarm every time it's time to administer the medication. And then I did just set this client up with the fall detectors as well. So they're now receiving very similar services as the first person. But again, it's a unique way of utilizing remote caregivers and the things that caregivers can do without having to have somebody in person to do those things. Next slide. Okay. So this is remote caregiving, or this is, I mentioned earlier, the remote monitoring service. And so what this is a series of sensors that are placed around the home. In this case, this client has dementia and family live nearby, but they're not there all the time. And what we've done is we put motion sensors in most rooms of the home, as well as on the doors that lead outside of the house. And so in a couple of cases, this client has woken up in the middle of the night and decided it was time to go to church. And the alarm notified the remote care coordinator team that they had left the home, and they were able to notify the family, who was able to go collect the client at the end of the driveway while they were waiting for the bus to church. So fortunately, this client didn't get lost, also didn't get exposed to cold weather, which could end up in a really bad situation. And then in another case, especially with clients with dementia, they just don't remember how often they go to the bathroom and they aren't able to communicate subtle changes in their health. So the detectors picked up that this client was going to the bathroom more often. And as a result, the family was able to take the client to the doctor, who determined that they had a urinary tract infection. So as you may know, UTIs are not a good thing to have. And so this was able to detect that and to help them prevent something that could have been worse. Like I said, the remote monitoring service is really powerful when it's paired with remote caregiver service. And so I am seeing more and more where the remote caregiver service and the remote monitoring service are being bundled together. I just thought I would put that in there. Next slide. This is the last scenario. This is one of my favorite ones and probably the most powerful use of remote support. So this client had been in rehab for a stroke. They wanted to return home. Of course, they were concerned about being able to manage their new health situation and were also fearful of falling. So I set them up with the vital monitoring equipment. And the vital monitoring equipment, they got a scale, a pulse oximeter, and a blood pressure cuff. And those were automatically synced to an app on their phone. So whenever they took those readings, which they're told to before 10 a.m. every morning, then the app automatically syncs with the remote care coordinator team. And if there are any significant or concerning changes in the client's vitals, the system will be able to pick that up. Remote care coordinators can check up and follow up with the client. And then if needed, we can intervene early. And what we have seen as a result of this is a reduction in return to the hospital. So when I mentioned earlier about helping people reduce rehospitalizations after going to the hospital for the first time. This is how we do this. We monitor the vitals, and with the senior population, particularly when taking numbers, it's hard to get them to enter that data into an app. And so the fact that this is automatically done and automatically synced with the remote care coordinator team, they can do that. They're also going to go through a questionnaire every day, just like the remote caregiver service, related to their chronic diseases. And of course, if there are any concerns, then we can flag that to my manager of care services, who might be able to intervene earlier. And then in conjunction with the remote monitoring service, this is absolutely a very powerful way to help people stay at home. So those are the 4 scenarios I have. We'll go to the next slide. Really, this is available to anyone that can afford it privately, but then the Medicaid waivers, either the home and community-based services or the community first choice waivers, also cover this. So the way to get it is to reach out to me. I will talk with the client, find out what they need, what they want, what they're willing to have, and then I will work with their case manager, who will approve it and put it on their PAR. Next slide. So really, if you want to get started, you can call me at 303-515-6755. I'll do the consultation. I'll identify what you need, and then we'll make sure we get the right tools, and then set it up, learn it, integrate it into the daily routine. Because these are so customizable and there's so much that's available, I do tell people, usually the way we start using it is not the way that we end up using it, just because we can learn. All right, I see questions coming through. So, number 1, private pay cost. It is not considered a DME. Private pay cost is usually $200 to $300 per service, and then of course, if it's bundled, then we can negotiate from there. And then, what geographic areas do I cover? Comfort Care covers the entire Front Range, and with remote supports, I can go anywhere in Colorado through Medicaid. And then privately, yeah, good question. Do we have monitoring devices, for example, the stove? San Luis Valley, yeah, I can go there. Go to San Luis Valley. Monitoring devices for the stove, not specifically, but I do have a client that gets a remote caregiver call every night before they go to bed. And one of the things they do check on is to make sure that all of the things that can be an issue are turned off. However, specifically, my systems aren't designed to watch for a stove that turned on. Did that answer my question, or your question?
It did. Thank you.
Cool. Yeah. I do know of some services. I'd have to look up the name, but there are some things available for that. Any other questions? I think that's it for me. There's my contact information. Save it. Please email me, call me. But really, this is designed to help people stay at home, and to be safe and independent at home. So as much as we can, let's use technology to be able to do that. And then, of course, I can provide in-person care as well. If there are no other further questions, I think I'm done.
Thank you, Derek. Appreciate your time today, as always, and hope to see you at some future meetings as well.
I'd love to. Thank you.
Thank you. Bye-bye. So for the rest of the meeting, I'd like to open up the time for anyone that has any questions for me. And I apologize, I should have introduced myself at the beginning of the meeting. My name is Susie Bachler. I am the lead for Group and Reach. Sammy typically does this meeting. She's the lead for individual inReach, but she is actually out in the field helping do individual inReach. And then on the bottom, we have our department division director and our access unit supervisor, if you would at any point need their contact information. But I would like to open up the meeting for any questions, any concerns that you have that I might be able to address and answer. If I can't answer it, I can certainly find someone for you to answer it. So I'm going to open it up. You can come off mute. You can type in the chat section, whatever works easiest for you.
So Susie, I just wanted to bring up if anyone else has any suggestions for topics for future meetings. I know this kind of sparked a lot of information about transition services and also helping hands and remote services. So if there's anything else you guys would like us to bring to this meeting, and this is Sarah Geisler. I'm also one of the inReach coordinators. We would just like to go ahead and make sure we're filtering in some of the topics that you guys feel like would be good for this meeting and these for the social workers here.
Thank you, Sarah. Good point. If anybody has any topics they'd like to drop in the chat, I can keep them and talk to Sammy about it when she's back. Also, Jay just answered the question about moving from an assisted living facility into the community. So it cannot be used to transfer from an assisted living facility, only out of the skilled nursing facility, either into an assisted living or into the community.
You got it. Thank you, Susie.
Thank you. Any other questions any of us can answer? And I just want to say, if you don't want to ask us on this big group call, you can certainly feel free to email us individually and we can have a one-on-one discussion. But yeah, love to hear any comments, concerns, questions that anybody has. If I don't see any, then you're going to get a little bit of time back in your day. Any questions? Anyone want me to call them individually? I'm not seeing anything. I just want to say thank you all so much for attending these meetings. We do want these meetings to be for you and of interest for you. So like Sarah said, please let us know what you'd like to see in the future. Because this meeting is for you, and I thank you all for attending. We get a pretty good crowd recently, and you can also have anyone from your facility join that you think would benefit from this as well. So thank you all again so much for your time and for attending this. I'll stay on a few minutes to see if anybody wants to ask me anything directly, but thank you again for coming.